well as interventional pain. So I primarily do interventional pain here at Sarasota Memorial. I was asked to talk about back pain and treatment. So I assume people here have back pain. How many people here have back pain? Because otherwise you wouldn't give up this beautiful day to come hang out with me, right? So today we're going to talk about back pain. If you have any questions, please just raise your hand. If you can't hear me, if I'm talking too fast, let me know. It's okay. I get yelled at all day long. So first of all, how frequent and what impact does low back pain have, right? So 90% of you raised your hand and said you have back pain. And people that aren't just coming to lectures by me, in the States, about 50% of Americans have back pain in a year. So that's a pretty high number. 7.5% of those patients with back pain, who don't improve with conservative management, and we'll talk about what that is, they'll improve in about a year. 75% of people will improve with just doing nothing. Now, obviously, you guys are here, so I doubt that happened for you, right? Most back pain gets better in about 2 months. It's expensive. So back pain accounts for about $20 billion of loss in work days. So it's an expensive thing. It's not just that your back hurts, but you're missing time from work, medications, treatments, surgeries, everything adds up. It gets very expensive. There's about $100 billion loss in direct and indirect costs. It's the leading cause of disability in less than a 45-year-old age group. So this says, you can read it for yourself, but it says, since we got up on all fours, or since we got off of all fours, I've been having these low back pains. So, you know, are we really made to walk and stand on 2 legs? So looking at the spine, cervical spine is up here. I don't have a pointer. I have a pen, I think. Cervical spine is up here, thoracic spine, and I'm mostly talking about the lumbar spine, which is down here, okay? There's different causes of mechanical back pain. So I'm going to talk about non-cancer pain today. There are lots of reasons for back pain. I'm going to narrow it down just because we can't talk about all of them in an hour. The number one thing that I see the number one cause that I see for back pain here in Sarasota are the facet joints, okay? So if this is a spine model, these joints right here, these are facet joints. And what facet joints are, where the vertebral body of one vertebrae meet the vertebral body of the one below, they form a joint. And anywhere in our body when we have a joint, just like in our hands and our feet, we have the ability to have arthritis. So, you know, those aches and pains in the morning when you wake up that you're taking your NSAIDs for, that your doctor's yelling at you because you're taking your NSAIDs for, that arthritis. And that's most of my patients. The discs, so the discs sit between the vertebral bodies, and discs herniate. And so those are those people that you say, oh, I have sciatica, and I have this pain in my leg. You know, discs, they have degenerative changes through time, and it forces them back. And so when they go back, they push on structures, and one of the structures is the nerve root, and we'll talk about that a little bit. You can have a combination. So the facets are in the back. So if this is the back of you, back here, the discs are a little bit more forward. So if the disc is pushing back, or the facets, which are the joints, are enlarged in the front, it narrows this canal, and this is the spinal canal, and that's where our spinal cord goes. And so, you know, then we talk about things called spinal stenosis or lumbar spinal stenosis, and so that's another cause of back pain. Also, the sacroiliac joint, which is the lower part of the spine, especially people who have had surgery on their back, it is also a place for arthritis. So the pelvis comes and it meets the sacrum right in this area, and it forms a large joint, which is the sacroiliac joint, and that can become arthritic and very painful. So just like in our model, these Is it working? Problem, right? Hi, again, is this working? Okay. So the facet joints, which are these joints back here, that's what they look like in the bone, right? So what happens is when people have arthritis, pain is usually worse when? It's worse in the morning when you wake up, right? Or if you've been sitting listening to a long, boring lecture by me, then you go to stand up, and that's when your pain is hurting you, okay? So the facet joints are usually worse when people are standing upright, walking, or moving positions. So if you look at the spine, if I put pressure and I'm standing upright and leaning backwards, that's going to cause more strain on that joint, and that's when it hurts the worst. And so the other common thing that people complain about with the facet joints is that they go to golf, and their back hurts when they're golfing because it's putting more pressure on those joints. The discs sit between the vertebral bodies, right? And they can herniate back. And again, these holes, these are called foramen. These are where the nerve roots come out. And so when these discs push back, they can push on these nerve roots. A lot of times people complain of pain mostly in their legs, back pain, but also radiating down the legs. Spinal canal, which is this part in the middle, like I showed you, this can also become narrowed, spinal stenosis, when the joints are enlarged because they're arthritic, or the disc is pushing back, or both. So it can be a combination. Or there's ligaments that become thickened, and that can also narrow. And so all of this pressure, spinal stenosis is usually that patient that comes to me and they say, I've got back pain, and when I'm at the grocery store, I have to lean over the grocery cart to walk because it hurts very, very bad. And those are usually my spinal stenosis patients. So where do I get this information from? I get a lot of information from people when they tell me their history. So that's why I ask questions. When's your pain the worst? What does it feel like? Is it better when you're walking, sitting, standing, moving? Did it start all of a sudden, or have you had it for a long time? Did you ever have a trauma? Did something happen to you? What was the mechanism? So a lot of the information that I get from my patients about their back pain is just by those simple questions. And, MRIs help so much, but really I want to know what are those mechanisms that are causing that pain. Most frequent cause of low back pain, especially in the 45-year-old group or the 45-year-old younger, is sprain or strain, and that's just your muscles. So maybe those weekend people that haven't exercised in 20 years, and all of a sudden they decide they're going to play basketball with their friends. And so they go and they do those weekend warrior type of activities, and all of a sudden on Monday morning they're showing up to work because their back hurts. That usually resolves. Back pain gets better with non-steroidal anti-inflammatories. Those are your medications like Advil, Aleve, Mobic, Celebrex. Physical therapy is helpful, ultrasound, massage. Rest versus activity. Some people say, well, my back hurts, I don't want to move. But, unless there's some really good reason why you shouldn't move, we want people up and moving. We don't want people to lay in bed for several days at a time. There's lots of reasons for that. One of the biggest reasons, especially, in my population of patients, I have I have all different kinds of age groups, but in my older population of patients, especially, the more we lay down, if you've ever had the flu and you're down for a week, it's harder to get back up because every day that you're down, you lose about 1% of body mass or body muscle mass. And so, we don't want you laying down. We want you up and moving and about. So facet joints, these are these joints back here, right? Can you see it? I'm sorry. These are these facets back here. It makes up 30 to 40% of back pain. I would say in my patients it's about 80%. It can refer pain. So the facet joints can shoot pain down the legs. So sometimes people say, oh, I have sciatica. It's not necessarily sciatica. It's those facet joints, and they radiate pain down the legs. It can sometimes be tender. So, you know, when we're examining you and we're pushing on your back, it can hurt. Usually what I have people do is I have them stand up in front of me, and I'll have them twist and kind of lean back. And so all I'm doing is having them twist and lean back, and I'm trying to reproduce that pain. I'm trying to cause that pain. That's what I do. I cause pain in people all day long. So I have them twist and lean back, and that usually reproduces pain in the facet joints. It's like I said, it's usually if you go from different positions. So if you're sitting for a while and then you go to stand up, that's usually when it hurts the worst. Or you are in bed and you're turning, or you're twisting, or you go to pick up your grandkid and and your back's hurting you. It's usually improved by sitting. So most people that have facet joint arthritis like to sit, and it makes them feel better. We use injections to diagnose where somebody's pain is coming from. So a lot of what I do is injection therapy. We also do medication management. But what we primarily do, once I've had a patient in my office and I've talked to you and I've said, where's your pain coming from? And I have I've looked at an MRI. The most definitive way of understanding where the pain comes from is actually by taking a needle under X-ray to that joint and injecting local anesthetic. And what that tells me is if that person has relief of that pain, meaning greater than 50% relief, that usually tells me that that's probably where their pain's coming from, and it's maybe not coming from one of those other generators. So once again, to tell you about how the facet joint, the motion. So, when you lean forward, if you bend forward, what happens is that the vertebral bodies become closer together, right? Because your body is constantly in motion, and joints move on each other. Your fingers move on each other. They're not always in that straight line like we see in a picture. When your vertebral bodies move close together, what happens, for example, and I'll talk about this again later, with somebody with disc pain, if this becomes closer to this, the disc pushes back. And so a lot of times when people have disc pain, bending forward makes them worse. If somebody has facet pain, this facet is going to put more pressure on this facet, and it's going to reproduce the pain on this side. So that's somebody with disc pain. Traditionally, if they're sitting or they're bending forward, it causes more pain. Somebody with facet pain, if they're standing, they're walking, they're twisting, it's going to irritate their facets more. Does that make sense? Most of what we do are injections, and those injections are done under X-ray. So when patients come and we're doing a diagnostic block, for instance, we do them in the procedure suite, so the OR. And we have an X-ray machine. So the X-ray machine allows me to see nothing other than bone. So I don't see the spinal cord, I don't see the nerves, I see the bone. And what I'm looking for is specific places. So for instance, in a facet joint injection, we can see the facets, and we can take a needle and put it exactly in that spot. So the reason why I tell you that it's diagnostic, the reason why I tell you if I inject that with a medication is because I can see where my needle is, and without a doubt, I know that I put it in the right spot. Sometimes if you've ever had a doctor just kind of inject your muscle in the office, they're what we call doing a blind injection. So they can't exactly see where they're putting it where your pain is. Here, I can take a needle, and I can see my needle tip, and I can put it exactly to that spot and deliver a very small amount of medication just to see if that's where your pain is coming from. Okay. there you go. Okay, hi. Do you have a question? Sure. I think that's a very good question. Did everybody hear her question? Okay. So she had some sort of complication. It's called arachnoiditis, which is inflammation of the nerve roots of basically the cauda. So the spinal cord, it ends up here. It ends up about L1 or L2, and then it has nerve roots that go down. And if those nerve roots get irritated somehow, they become inflamed and they kind of clump together, and it becomes very painful. It's a very painful thing to live with, right? So the question is how do you know if you're going to have a complication from one of these procedures, right? That's your question. It's a very good question. And my answer, obviously, is I don't know, right? I can't predict whether or not somebody's going to have a complication. The thing that I tell my patients, I am human, you are human, right? I hope, I pray that nothing will happen, but you can never predict whether something's going to happen. The things that I can tell you is this. We have less complications when we started using X-ray, okay? Because there used to be, years ago, 10, 15 years ago, a lot of these procedures were done without the use of imaging, so I couldn't see where my needle was. I can also tell you that the level of training that somebody has had to do these procedures, it matters, okay? All of our physicians at Sarasota Memorial are board certified in pain medicine, right? There are some physicians that do these procedures that maybe did not have as much training. I'm not saying they're bad doctors. I'm saying that I'm a better doctor for having more training, okay? I did a 2-year fellowship under having somebody watch me do everything I did for 2 years, and just to get to do what I do, right? So there are some physicians that didn't have that, and like you said, it's a complicated procedure. It's right by the spine. It can be very scary. The risk of complications is less than 1%, so it's really low. I know that something happened to you, and something can happen to anybody, and unfortunately, we don't want those things to happen. The risks are really low. The risk of arachnoiditis is higher with more of like an epidural than it would be with a facet injection, because the facets are out here. The epidurals are a little deeper, but you can't predict those things. Yes. Yeah. Spontaneous. Mm-hmm. And it does, and so the other part of what we try to do as physicians is we try to minimize risks, right? So part of the things that myself and my nurses are asking patients, do you take any blood thinners? Have you had any infections? Are you on any antibiotics? Have you had any fevers? And if some of those questions are yes, then I won't do the procedure, or I'll wait to do the procedure, because what we do are elective procedures, right? It's not like you have chest pain and you need a heart surgery and you have to go because the doctor says you're not leaving. These are elective, so these are choices. These are planned procedures. So we really do minimize risks by, trying to do everything we can to set you up for success and not failure, right? Okay, I don't mind. You'll have to ask these people, but I don't mind. Sure. So the lamina is a piece of bone, okay? So I'm not a spine surgeon, but I can tell you that a laminectomy is a very common procedure. If somebody's disc is herniated, so if the disc is herniated and putting pressure on the nerve, for instance, and you're having lots of pain in your leg, or you have foot drop, or your leg isn't moving, sometimes the surgeon will go in and they cut this bone right here. And that bone right there is called the lamina. And so we like to keep things simple for us, and we call it a laminectomy, and that just means removing some of that bone. All it does is this space right here, which is the central canal, all it does is it relieves pressure and it opens that up a little bit so that you're not having as much pressure on that nerve. Yep. You're welcome. Yes, ma'am? Okay. So the question was, what happens if you've had multiple of these injections and they don't work anymore, or they're not working? Part of having good success with the injection is selecting the right patient, right? So, do they have facet disease? Do they have disc disease? Because it helps choose which procedure you're going to do, right? So the first step is to make sure that you're doing the right procedure for the right patient. Sometimes the injections stop working. So for an epidural, for instance, the reason why we do epidurals is because we flush steroid into the epidural space and we try to decrease inflammation. After some time, you can have less efficacy, meaning that the injection just doesn't work anymore, whether it be because it's too crowded, or it's not an inflammation problem, it's now a mechanical problem, and so you can inject all the steroid you want, but the mechanical changes that happen in the spine, they won't improve with steroid. So typically, if somebody doesn't improve with injections anymore, and you've gone back to square one, and maybe you've done an MRI again, or you've re-examined the patient, you look at alternative techniques. Sometimes spinal cord stimulation is a choice, which helps with back pain and leg pain, which I'll talk about in a little bit. And then, and sometimes just seeing a surgeon and seeing if they have anything to offer. Sometimes that's a choice. Medication management is sometimes a choice. So, non-steroidal anti-inflammatories, physical therapy, and then sometimes opiates, pain medicines like Percocet, and it's a scary word, I know, but so back pain is it's not like getting your car worked on and you say, well, the alternator's not working, let's replace the alternator. Back pain is a multimodal approach, okay? And there's never one cookbook to it. That's why when patients come, they talk, we're thinking every time. It's not like, okay, you have this and off you go and we're gonna do this and that's it. There's multiple reasons for back pain, which is what I'm just getting at today. There's lots of reasons for it. You have to identify those reasons, and then choose different therapies to help the person. And it's not a one size fits all. So there's usually always something to help. The other thing I tell patients, and I say it a lot, I don't expect to take all of your pain away. And nobody wants to hear that, right? So people come to see me and my pain is an 8 out of 10 and it's in my back and it's all the time. It's probably been an 8 out of 10 for 20 years, okay? And it didn't get there overnight. I rarely believe that I'm gonna get your pain to a 0. Do I want that for my patients? Absolutely. I want your pain to be a 0. Is it gonna happen? Probably not. They did a study a long time ago, and they took normal adults without back pain, without healthy, normal adults. I don't even know what that means. average adult has a back pain of 4 to 5. So if that person doesn't have the chronic back pain or the arachnoiditis or the back surgery, and their average pain is 4 to 5, why am I going to get you to 0? I want to, but it's probably not going to happen. So that's, sometimes we want to get the pain to a level where people can be functional and do the things they want to do, and whatever that means for you. We try our hardest. If your goal is to go to work, and do those things at work, we try to figure out how we can help you do that. It's like I said, it's never an easy cookbook. Yeah? Yes? So the facet injection, taking a needle either to this joint. So there's multiple joints. I'm just pointing at one, right? So we localize the level of where the joint is, but taking a needle to the joints, or we take a needle to what's called the medial branch nerve, okay? So the medial branch nerve is not on this model, but it sits in a very specific location. It sits, this part right here, this is called the transverse process, okay? And this part right here is called the superior articular facet, and they're just fancy words. Where this bone meets this bone down here, I know it's hard to see because I'm out of hands, the nerve sits there. Every joint has 2 nerves that innervate it, except for the bottom joint, which actually has 3. So sometimes we do what's called a medial branch block, which is essentially the same as doing a facet injection. It's just a different type of procedure. So sometimes the injection is here at the medial branch nerve, and sometimes the injection is directly into the joint. They both serve the same purpose, which is this where your pain's coming from? Well, that's usually surgeon dependent. So generally speaking, I will do the medial branch nerve, and that's just my preference, because the reason being is later when I do what's called a radiofrequency ablation, which is a nerve burning, I'm going to burn that nerve. So if I'm testing something, I want to test the nerve because that's what I'm actually burning. Some physicians want to do the facets because they feel they get better results with that, and we all think we're right. Both. So the injection is diagnostic and it's therapeutic, okay? So it's diagnostic, meaning, is this where your pain is coming from, right? It's therapeutic because generally speaking, we will put a little bit of steroid in there to hopefully give you a little bit longer lasting relief. So the medication generally has a local anesthetic, and so like when you go to the dentist, you're numb, for the day, but it wears off, right? That's local anesthetic. It's usually lidocaine. I usually put what's called bupivacaine. It's a longer-acting local anesthetic. It lasts for about 6 to 8 hours. But I combine that with a steroid to hopefully give you a little bit longer-lasting relief. The only part I care about as a clinician for that initial block is the bupivacaine, because I only care about that first day. I want to know if your pain is relieved that first day and how much relief you have. Well, if we're talking about the medial branch block or the facet injection, that's a shorter amount of time. If we're talking about the radiofrequency, which is the whole reason why we do the medial branch block, it's usually 6 months to a year to 2 years relief, depending on how quickly your nerves repair themselves. Yes, sir. Sure. I don't. The surgeon. That depends on the surgeon. So typically they'll do, it depends on the surgeon. So it depends on how many levels have nerve impingement, right? So if you have 3 levels with nerve impingement, then they do a 3-level laminectomy. If you have 1 level, they do a 1-level laminectomy. Some surgeons, if the laminectomy is too great, meaning it's more unstable, then they'll put a fusion. So they'll put a plate with screws. That's a surgeon question. Yes. Yes. Okay. Great questions, by the way. Okay, so the disc. And the reason why I point out is the facets versus the disc is because there's a lot of similar things, and then there's differences, but the treatment's a little bit different. So the disc pain, this is the disc right here, okay? So this is a MRI of a fairly normal spine. Your spines probably do not look like this. My spine doesn't look like this. This is the back of the person. This is the front of the person. So it would be like if we took this model and we're looking like this. So what we see are the discs, the vertebral bodies. So the discs and the vertebral bodies. This is the spinal cord up here. It ends right about here. It ends up at about L1, L2. It doesn't go all the way down. The discs usually look like this. See how it's a lighter color? This white stuff right here, this is CSF, cerebral spinal fluid. It's what the spinal cord sits in. These discs have that lighter color because they have fluid in them, not CSF, but fluid. So they're cushions. They help us cushion. Usually the discs are in the same line with the bones, right? So if it's herniated, it's going to push back. So this is an example of a disc that is more degenerated. So remember I told you that these discs are more lighter colored. When you get that MRI and somebody says, oh, I have degenerated discs, what are you looking at? Well, this is a degenerated disc. It's dehydrated. It's losing that fluid inside. So once again, the discs, they herniate. They don't usually herniate straight back because there's a ligament that sits there, the posterior longitudinal ligament. So what they do is they usually herniate to the side, so they go lateral. So they go back and to the side, and what sits there are these nerve roots. And so that's why when they hit those nerve roots, that's that electrical shock that you feel going down your leg. So these are MRIs that are abnormal, right? So the normal one that I showed you, the disc is usually light colored. It's usually in line with the bones. This disc is huge. It's herniated. It's pushing back. It's probably causing that person a lot of pain. Same thing here. This disc is huge. It's pushing back. You know, this disc is darker colored. It's not that light, bright color. So it's degenerated, and then after time, when discs are degenerated, sometimes they herniate back. What? Which picture? This one? Up where? This stuff? Oh, okay. That is muscles, and so there's bones back. So this is just one cut through the person. So it's different if you're looking at the image the way I am, because I can kind of glide through and I can see different levels. There's different cuts. So this is one cut. But there's muscles in there. There's bones back here because of the spinous process. And so you're seeing, you know, that's where some of the facet joints are. It's not a good image. The only reason why the image is up there is so that you can see the disc herniated. Good question, though. So the symptoms of disc disease. So, you know, how does it start? Well, you could be sitting. So like I said, if you're sitting, you're bending forward. This bone becomes closer to this bone in the front, and what happens, it pushes the disc back. And so that makes things worse. You're driving in the car. You're sitting in the chair. You know, you bend over to pick up the paper. And so when that occurs, then you get this shooting pain down your leg. That's what a lot of people complain of. It's increased with things like increased intra-abdominal pressure. You're coughing, you're sneezing. Those put pressure on your spine. You bend forward, and it pushes that disc back. But but the one thing that we do know, MRIs are very, very, very specific, okay? So a lot of times people come to me and they say, well, I had an MRI done, and my L4-5 has a disc herniated, and so you need to fix it, right? And so usually my first question is it hurting you? No, it doesn't hurt me. Well, why do you want me to do anything? In 50 to 60% of people with normal backs, normal meaning they don't have any pain, they actually have abnormal MRIs. So it's not that uncommon to see a person with an abnormal MRI. It doesn't mean that your pain is coming from there. It doesn't mean that you have pain. It doesn't mean that it has to hurt you. It's just defining. Sometimes in medicine we have tests, and sometimes they're too specific. We use MRIs to guide us. We use physical exams to guide us. We use the history to guide us, and we have to put it all together. It's just a big puzzle. But just because somebody has an MRI with a herniated disc doesn't mean that disc is causing them a problem. Does that make sense? Okay, so the other thing to tease out is that in the body, different pain generators can refer pain, okay? So the hip, there's a bone right here. You can feel it on your own leg. It's called the greater trochanter of the femur, and there's a bursa over it. Okay, so everywhere in your body where a muscle goes over a bone, it creates a small fluid sac called a bursa. And those bursas don't always hurt, but if you've seen somebody's elbow that kind of gets very large because they say I have a bursitis in my elbow, you can get that in your hip as well. And that can refer pain down your leg, okay? But those facets, which we talked about, when people are standing up, it can also refer pain down your leg. And so you start to see that these kind of overlap. So not all pain down the leg is from the bursa, not all pain down the leg is from the facet, right? It's kind of tricky. And also the sacroiliac joint, which we talked about, where the sacrum meets the pelvis down here, that also can send pain down the leg. It doesn't mean that it's sciatica. It doesn't mean that it's a herniated disc. It just means that you have pain out of the leg. So the point of talking about this is that different pains overlap, and part of what we do in our clinic is try to tease that out and try to help you identify where that pain's coming from, whether it be history, physical exam, injections, to tell us, does that pain get better? Oh, it's probably from your hip. The nerve roots also radiate pain. I'll get to you in 1 second. I'm sorry. The nerve roots also refer pain. So when these nerves are pinched, for instance, L5 refers pain down here. So, if L5 is getting pinched from the disc up here in your back, it may just show up as you have numbness, tingling, burning in your foot. And so, some people will come to me, well, I just have foot pain. Okay, I'm going to MRI your back. Why are you MRIing my back? Because your foot hurts, And so the body refers pain. If you've heard of somebody having a heart attack and they say, well, I had arm pain and that's all I had. The heart refers pain to the left arm, and the gallbladder refers pain to the shoulder. So, our body sends pain to different areas because that's what it wants to do. What was your question? The referred pain? If you're having referred pain from the hip, what is it doing to your back? What is it doing to your hip? I don't know that it's doing anything to the hip. I think the hip is just doing it to the pain. I mean, the hip is telling you it has pain. It's not worsening the pathology in your hip, but it's just saying, hey, I've got something going on. Well, that's a complicated question. He says by walking and doing things, you're not damaging. Typically, if you're not a 20-year-old football player, with a lot of testosterone, you're probably not going to hurt yourself, okay? Your body has checks and balances in it, right? Muscles. So when we are hurting in our hip, for instance, you might feel a spasm in your back or your knee or your leg, and that's your body's way of saying, stop it, right? So, unless you're, unless you're that exotic athlete that's out there and you don't care that your mind says I'm in pain, you're probably not going to hurt yourself. There are some exceptions, so I say that very, very carefully. Okay, so how is low back pain treated in 10 minutes or less? But very good questions. Okay, so one thing that we use, and we use a lot, conservative management, right? So what is conservative management? Conservative management is if it hurts, stop it, right? Anti-inflammatories, because they decrease inflammation, because most pain is some sort of inflammation. Arthritis is inflammation. You want to decrease the inflammation to decrease the pain. TENS unit. A TENS unit is that machine that has stickers and you put it on your back and it shocks and it provides some relief. It's not a medicine. It doesn't make you sleepy. It's that nice kind of comfort thing that you can put on all day long. Some people use acupuncture. We use medicines. We use muscle relaxants to try to relax the spasms in your back. Physical therapy, very often when somebody comes to my clinic and they say, I have back pain, one of my top questions are, have you had physical therapy and how long ago was it? Typically when people go to physical therapy, they do those exercises, and then physical therapy's over and then they stop. It's kind of, it doesn't help if you stop. You have to keep doing it. And so sometimes we need to be reminded how to do it, and so I'll send somebody back to physical therapy just to get an exercise program to do at home. They say, well, I'm going to the gym. Okay, that's good. I'm going to send you to the therapist, let them watch you, make sure you're doing those exercises properly, and that way, you don't hurt your back worse. Hot and cold, everybody asks me the question of which is better, heat packs or cold packs. It doesn't matter. It's whatever makes you feel better. If heat makes you feel better, do that. Some people use traction in physical therapy where they kind of pull the spine apart. The therapist, sometimes you've seen, they'll put it on your neck and kind of lift it up. Always do it under the guidance of a physical therapist. Back school. Keeping our core strong. So important and things that seem very easy, but we miss, right? Weight loss. The first thing that you hear about a pregnant woman who's carrying a large belly is, my back hurts. When you're carrying more weight, your center of gravity changes. So instead of walking in the posture that you're supposed to, you arch your back more. You arch your back more, you hurt your facets more. Or if you're carrying more weight, you bend forward more, or you want to sit more, and your disc is hurting, it's going to cause more pain. So weight loss, decrease that pressure on your spine. But also keeping your core muscles strong and your back muscles strong. Those are things that are going to help you throughout life. See, the point is that if you come in to see me and I do an injection on your back, that is the best time for you to start doing therapy and exercises, because you want to get as strong as possible so that you're successful and that you don't need to see me anymore. What's not recommended? Bed rest. We want you up and moving. A rat. So rats are used in medicine for experiments all the time. I know that's gross and it's after lunch, but I'm going to just break it to you. The tails are a lot like tendons, right? So there were some studies that were done that if you take that rat tail and you stretch it, what does that do, right? So if you take that rat tail, so this is a boring chart, but this is length and this is load, right? And if you take that rat tail and you keep it at 25 degrees Celsius and you stretch it, it's not going to get any longer, right? It's not going to elongate. But if you take that same rat tail and you heat it up to 45 degrees Celsius and you put a load on it and you stretch it, it's actually going to lengthen. And why is this important, and why am I talking about rats at 2 o'clock in the afternoon? Warm up, very good. Stretch your muscles. So it's not important to sit there and just stretch before you exercise. You should do a light 10-minute workout or use a heating pad. I mean, those are those purposes of why we do those things, so that you don't hurt yourself, number one, but so that you get the maximum stretch of those muscles, so that you have less back strain. Anybody know what this is? This I see a lot, okay? I see a lot because I see a lot of backs. So this is that patient that fell asleep on their heating pad or uses their heating pad too much or has had spine surgery on their back and their back is numb and their skin is numb, and then they're using a heating pad and you essentially burn yourself, right? And it's called erythema ab igni. Now, not only is it not pleasant to look at, they can't see it, they don't care, it can actually lead to cancer. So you have to watch it. You know, you don't, the reason why we tell you not to lay on your heating pad, one, because heat makes us sleepy and we fall asleep, it does me, but two, because you have more risk of burning yourself. That's why we get heating pads that have automatic timers. The number one cause of lawsuits, which I don't really want to share, but the number one cause of lawsuits to physical therapists is because somebody got burned. Because they take those hot packs and they put them on the patient, and then maybe they went to go help a different patient, the patient fell asleep, and they wake up burned, okay? So you have to be very careful. These are things that you can buy at the drugstore, but things at the drugstore can hurt you as well. So lifting, you know, stay close to the objects, don't keep your knees straight, bend your knees, don't lift too much. I mean, you know, you don't need to lift 50 pounds if you haven't done it in 30 years, you know. If it's too heavy, leave it there, somebody else will get it. There's really no reason why you need to. The thing is that those patients that I see, that this is what happens. Well, we were moving furniture and we were cleaning, and I went to lift this dresser. Have you lifted that dresser before? No. Well, why were you lifting? Because I needed to lift it. And they come to me and they break their back and they get a fracture in their vertebral body. You know, it's when your bones are getting softer through time, right, and we're getting osteoporosis in this day and age, and in Florida we have a lot of osteoporosis, lifting a 50-pound or 100-pound dresser, don't touch it. Just leave it there. It's okay if it has dust behind there. Nobody cares. Watch your posture. Keep your exercise up. No smoking. So smoking, you know, this is, well, who cares if I smoke? Well, your body needs to heal itself. And how does it heal itself? It sends blood to that area. And what's in blood is oxygen. And so, you know, if you don't send the good things to that area, to that muscle to heal yourself, your healing time is much, much longer. And the other thing that I see a lot, well, I'm just ignoring it, hoping it goes away. Well, those are those patients that I see. Okay, thank you. I have 10 minutes. This is not easy. Those patients that I see that come to me, they say, I just ignored it. And they come with a vertebral compression fracture, and then I put some cement in their vertebral compression fracture. Their back pain's better instantly. And they say, why did I wait that long? You know, we think because it's common and we like to treat ourselves and we like to go on the internet and we like to play Google Doctor and it's fine, it's got to be this. But, you know, getting it treated early is much better than waiting, because, you know, you could have improvement a lot sooner instead of sitting at home being in pain. Okay, so I have 10 minutes and I know I have way more slides. So I will keep going, or if you guys prefer questions, we can do that. So, go ahead and answer. Yeah. Spondylolisthesis or spondylosis? Spondylosis is a big fancy medical term for arthritis of the facets. It's on most people's MRIs. Spondylolisthesis is a slippage. So what happens is this bone slips forward or this bone slips backwards. And if it slips too much, it needs to be surgically corrected. Yes. Or flexion extension x-rays. Yes, sir. The number one, or the primary finding for facet osteoarthritis or facet joint arthritis is spasm of the paraspinal muscle. So the first sign of arthritis in the facet joints is spasm in the muscle. Spasm could just be spasm. Spasm could be the sign of a disc that's herniated. So usually spasm is because your body's telling you that something is going on, and it's trying to protect you from continuing to hurt yourself. I would. So those are good questions. Those I leave to the physical therapist, because then they can be with you one-on-one and show you those exercises. Yes? Does anybody want to try to answer that? Yes. Arthritis is always worse in the morning, exactly. So if you're not moving, you know, kind of freeze for a while, and so it's just trying to get through that pain, and usually in the first half hour that improves. Sure. Probably not advisable. The FDA has released a lot of warnings, especially in the last year. I'm sure you've seen the news. NSAIDs can cause renal insufficiency, which is narrowing in the arteries of the kidney. They can cause cardiac problems. They can cause gastritis and ulcer. So, you know, everything is risk versus benefit, right? So in medicine, it's okay, so what's the lesser of two evils? And part of our job as healthcare providers is giving you the education to understand what the risk versus benefit is, and to help you determine what is the best treatment solution for you. I know, it's not an easy job. So NSAIDs, muscle relaxers, sometimes we use things, they're called anticonvulsants. Those are neuromodulators. That's your gabapentin, your Lyrica. I'm sure you've all seen a commercial for Lyrica or Cymbalta. We use those for pain. They're all good reasons for pain. And we don't just use one, we use many, because these medicines, they work on each other. They help each other work, and they do different purposes. Opiates are prescription medications are the second most abused drug in the United States, secondary to marijuana. We're seeing a huge rise right now in illicit drugs like heroin, right? And you're seeing people dying on the news. It's very scary. It's because we've managed to try to control some of the abuse of OxyContin. And what happens is when people are addicted to one drug and you take that away, they find another drug. And so it's very sad that we're finding people dying every day over other drugs now. These medications are good medications. They help people, but they're also very dangerous medications. And so, you know, these are always conversations that you have to have with your doctor, whether it's appropriate or not. You know, my job when I see a patient is this an appropriate drug for this medication? Because I don't want to put these drugs on the street. I don't want these drugs to be given to the wrong person. I don't want somebody to have their house broken into and these medications stolen so that somebody can abuse them. And those are things that I worry about as a doctor every day, because I don't want to put people in jeopardy either. U.S. uses 99% of the world's consumption of hydrocodone. Now, yes, we're a little greedy. Part of that reason was hydrocodone was a Scheduled III drug previously. So it used to be that I could call the pharmacy and say, this patient needs hydrocodone, go ahead and give this to them. And they would give it without a prescription. They could take a verbal order. Now it's a Scheduled II drug. That happened about a year ago. And so we'll probably see that number drop a little bit because it's more controlled. So the question was, do I think that somebody could live on the minimal dose of an oxycodone and that treats their pain? So, you know, I think that's acceptable if it's the right patient, the right selection, the side effects are understood. Obviously, we always try to keep the minimal amount of medications possible, and maybe that you've exhausted other treatments, right? So it's kind of a loaded question, because there's lots of variables to it, right? It's a good question. Do I have patients that they take 2 oxycodone a day and it helps them, you know, take their showers and go to the mall and maybe maybe do their grocery and it helps them do their activities of daily living. I have those patients, and they're very functional, and they don't have side effects, and they're not sedated, they're not falling over when they're in my office. So sometimes that is an appropriate treatment. It's person dependent. Holy moly, that's a whole hour conversation. That's a very good question, but if I even started that conversation, we would never leave. How are we on time? We have 3 minutes. Oh, no. It's always hard. Okay, I will keep going. So again, this is from the CDC. I just pulled it yesterday. This was released in 2016. They're always a couple years behind. But as you see, we see increased overdose deaths involving opioids, and it's still greater than, methadone and heroin. So, people are still abusing drugs, and so our job is to try to prevent that and not provide too many drugs into the community. Okay. Probably a good stopping point, but you're going to, how about, I think it would be more, because if I start with the next subject, then it's just going to, I do apologize, but I can happily answer any questions that you guys have. So let me just say this. So there's a lot of factors that go into back pain, right? And every patient is an individual, and we see every patient, and we do a physical exam and a history, and we try to listen to you and hear what it is that's causing your pain, and we try to get the appropriate images to try to help us and guide us with what we're already thinking in our minds. And we use injections, we use medication, therapy. I'm very bad with the microphone. Pain medicine is a multimodal approach, right? So there's no cookbook. There's no, I'm going to look at you and this is what you're getting, and that's it, and you're going to be fixed. We try to keep people functional, doing the things that we want to do. Maybe you're not going to go run track tomorrow, but if you haven't done it in 15 years, you're probably not going to go run track tomorrow. But we do want you to do those things that you enjoy, because that's what life's about, is doing the things that we enjoy. We do provide treatment options at the Sarasota Memorial Pain Program. And as you can see, there's it can't be answered in an hour. There are injections, there's physical therapy. For compression fractures, we do kyphoplasty and vertebroplasty, which is putting cement into the fractured area. These procedures, there are risks, there's complications. The biggest complication I've seen, knock on wood, which I don't have any, is pain at the injection site. We do everything we can to prevent those things, but obviously complications can happen as well. But mostly we just try to improve your pain and keep you functioning. Yes, sir. A lot of them, yes. Very similar. The facets are there, the discs are there. The canal is a lot more narrow, so spinal stenosis is a bigger deal, because in the lumbar spine, the central canal, even if you have herniation, it doesn't cause as much catastrophe as if it does in the neck. So you see a lot more surgeries in the neck, but very similar principles. You'd have to ask the surgeon. I bet they'd say yes. My job is to prevent people from having surgery. If I can do that, that's what I do. So am I ever going to tell you that surgery's better? Heck no. There are times when surgery's better. There's times when surgery is more appropriate. There's time when surgery is, okay, you can't walk, you're going to surgery. But for the most part, when we're talking about symptomatic pain, if I can prevent you from having surgery, that's my goal. So my answer is always no. Because I see the failures of surgery, I don't see the successes, right? So if you have surgery and you're doing great and you're back to playing golf and your back feels good, you don't need me, right? What I see is people that aren't doing well. And so I have a very skewed perception of what surgery does. There are some great surgeons in this area. They do good work. There are patients that do very well from surgery. I try very hard not to let those patients go to surgery. About myofascial pain, is that the question? I'm not exactly sure what the question is, but I will try. Yes, myofascial pain, yes. So, again, there's different causes of pain. Myofascial pain is more superficial, so it's the muscle and the tissue surrounding the muscle. Yes, that is a pain generator as well. How much of it is from the underlying facets causing the problem versus maybe the muscle itself? It's hard to tell until you see the person. Welcome. Anybody else? I think so. I will find out for you. That's a good question, too. Thank you, everybody, for your attention. I appreciate it.